perhaps the difficult thing that I did was trying to decide what I couldn't really talk about. But what I'd like to do, though, is I'd like to do two things. One, to learn the rules of dystonia, how to recognize it, and then what are the most important conditions that we will need to think about when we recognize the rules of dystonia have applied. These are my disclosures. I don't think any of them in any way will alter the content or modify what we're trying to use here. And this is essentially the overall flow, as you'll see, will develop. So first, how is it that we think about dystonia? It's probably best to think of dystonia as a patterned movement. So it's different from what you just heard from chorea, where there is no pattern necessarily. There's randomness to chorea. There is some pattern to dystonia, and that means that there is directionality. There is an axis to the movement, and the movements are induced typically on action. So that's very important. They are going to be action-induced, position-dependent, task-specific. And if you can build those words into the description of the movement that you're seeing, you're actually making the case. Those are the rules of dystonia. And when you ask patients to do movements in other body parts, you appreciate an enhancement of the movements in the affected body parts, something we call overflow. And then finally, there is this thing called a sensory feedback, which is a closed loop, a sensory trick, which is a closed loop sensory feedback. And what it means is that you can alter the behavior by essentially creating a circuit that implies that there is a sensory feedback that alters the motor output. And that's something that's very unique to dystonias. So the action inducement is very important, because one red flag in dystonia is when you see an abnormal posturing or an abnormal jerky movement that might be patterned, that might be have a directionality, but has appeared acutely. So acute presentations with very fixed posturing would not be consistent with dystonia, because it doesn't follow the flow here, where action inducement creates the movement, then eventually the movements can actually be occurring at rest by virtue of overflow, right? You're trying to do activities in unaffected body parts that bring on the dystonia, even when the affected limb isn't moving. And then finally, after many years, then dystonia can be present at rest, and that might be the case for Corticobasal syndrome, for instance, where you see that very commonly. I'm not going to go through what has become sort of a revised classification, but I only want to emphasize that we really are looking at first clinical features, and secondly, then we can define what kinds of etiologies we might be dealing with. And so we'll try to address some of this with examples rather than trying to memorize this here. But all of these features that we all go through are very important in terms of defining ultimately what type of dystonia we may be dealing with. So here, first is just an example of a very subtle form of dystonia. This is isolated head tremor, which could in some cases be thought of or confused with essential tremor. You see there is a directionality here. Their phases of tremor are irregular, which gives it a jerky appearance. As you see that the patient moves over, there is a point toward the direction of the movement where the tremor is actually much less. That is a null point, because the head is pointing in the direction of the pulling muscles, and she's finding that particular spot. And then finally, the patient can be asked to explore what, if anything, might happen with just touching herself in the face. That's the sensory trick, the closed-loop sensory feedback, and you see that there is an attenuation of the activity. So these are rules that, that we're going to be looking for in terms of our patients. Now, here you see in the next slide a patient that is having quite a bit of a jerky tremor. And again, here we are probably going to be thinking, is this a tremor, otherwise non-specified, which we refer to as essential tremor, or is this a dystonic tremor? And as you see, there is position sensitivity. It is action-induced. You can see that there wasn't anything at rest. Action brings it on. and it is somewhat direction specific. So those are rules, as you appreciated, that will be important. And tasks are very, very specific. So this is the patient writing, but she actually does something very unique, which is that I'm going to play this one. You see that she does this soldiering, which brings on, just like you saw with the writing, brings on the jerky tremor. Now, if we ask her to change the program, which means we are asking her to hold on that soldiering equipment differently, then the behavior will change. And so she actually is quite surprised. And
check you out!
I wanted to just play that bit because she actually was surprised by the fact that, that by changing the way in which she would use the tool, there will be a change in terms of the behavior. So that's another important feature. We want to make sure that this is tested. These activities that elicit the dystonia are tested in different ways because the program is very important, and that's where the task specificity comes in. So here, in terms of the classification, I think, again, I don't want to belabor this because I want to keep it very practical, but I want to keep in mind that dystonia can come in isolation or in combination with other genetic with other features. In the combination with other features is going to help us in terms of determining which type of genetic dystonia we might be dealing with. If it's exclusive dystonia arising in the lower limbs, DYT1 is going to be the most important of all of the dystonias. If it is exclusive dystonia in the upper body, DYT6. So those two top genes on the left are going to be the most important ones. If it's combined with any other movement disorders, there are two movement disorders that are important to recognize dystonia with: Parkinsonism, and that dystonia-Parkinsonism combination in Filipino will be nearly diagnostic of Lubbock disease, and it will be Lubbock disease until proven otherwise. And when it is associated in non-Lubbock populations and is associated with an earlier onset and levodopa response, we think of dopa-responsive dystonias. And then the other abnormality of movement present with dystonia is myoclonus. So if you have dystonia and myoclonus combined, then you're going to be thinking of DYT11. Those are the top three on the middle. And then the paroxysmal dyskinesias are sort of a category in and of themselves, and we'll touch upon them very, very briefly at the end. This is the typical pattern of DYT1, the most common form of lower limb dystonia at onset in childhood typically. This doesn't have to occur in childhood. If the age at onset in those who have the mutation is at a later stage, then we actually can see that the body part affected becomes the arm. It almost never is the face, so it can be the leg if it's a young onset, it can be then the arm if it's a later onset with the same mutation. And typically, this dystonia will generalize, except that may not happen if the onset is really over the age of 20 years. So if you have a 20-year onset of someone with dystonic manifestations of the hand, and that person can have DYT1 dystonia and will not really follow the rules of generalization that the ones with lower limb dystonia, much younger at an age of onset, will have. As I mentioned, DYT1 would be a condition where you think of dystonia at onset in the legs. If the dystonia is at onset in the upper body, and it's going to be the trunk, actually the oropharyngeal in the cervical region, think of DYT6, and this is actually the most common of the primary dystonias, isolated dystonias that occur at this age. If it comes with spasmodic dysphonia and there is family history, you really have to think of DYT6 because that might then become the most important of the diagnostic considerations. If you see dystonia that is affecting the cervical region and think about a family history, then the situation becomes just a little more murky. If it's myoclonic component, and this is not true myoclonus. If we do electrophysiology of the cervical muscles, we'll find that the jerks are really not within myoclonic range, which is under 100 milliseconds. These are sort of dystonic spasms, as they were called, just rapid jerks that still are within the range of dystonia. So think of DYT13. As I mentioned before, DYT6 is always to be thought of in patients with upper body involvement, and it could just be restricted to the cervical region. I had mentioned that Myoclonus-Dystonia is a condition to think of if you have a combination of dystonia and myoclonus. Sometimes, though, you might have only myoclonus or perhaps only dystonia, so you may not really think of this condition unless you are astute and you're trying to see patients in different phases. So for instance, patients may have these jerks, particularly the myoclonus affects the axial musculature. So you see as this patient drinks, there's a little bit of shoulder and neck movements. Particularly writing is the task that brings that on in a much better way. So in these patients, you always have to have them right. And I'm always looking at the neck and at the head and at the shoulders, because that's the region where the movements, particularly the myoclonus, begins. And this particular young man had this brother who only had the jerks when writing. At no other point he had any other neurological manifestations. So very important to have these patients tested when they are writing to be able to elicit the features. You could have thought that the brother was unaffected, but in fact that feature indicated that there was in fact an autosomal dominant transmission. There was that kind of familial history in this family. Importantly, this is one of the alcohol responsive conditions. So as you can imagine, if you're quickly thinking about this, somebody might think of a tremor, alcohol response. The diagnosis might be different. This is exquisitely sensitive to alcohol, and alcoholism becomes a problem in some of these patients. Now, we don't know if that's primary or secondary. Certainly, there is a lot of psychopathology in dystonia, Myoclonus-Dystonia that might, I should say, may be co-segregated with the gene. So moving on to dystonias that are secondary, this is an example of exercise-induced dystonia. This is a patient that you see here trying to elicit or demonstrate what happens with walking, obviously very disabling. This particular man, seen by Dr. Sethi. What we think in these patients now is we think that this could be a manifestation of early Parkinson's disease. Of course, there is a genetic condition called GLUT1 deficiency. GLUT1 deficiency much more common in younger individuals. So at this age, we sometimes think of Parkinson's, potentially a genetic form of Parkinson's disease that might be in the works and presenting with this type of thing. This patient on the right is a patient that actually does have Parkinson's disease, but presented with not a paroxysmal exercise-induced foot dystonia, but with a dystonia of the feet that was, and particularly the right more than the left, so asymmetric, suggesting that there is a phenotype of Parkinson's, particularly younger individuals who present with dystonic features, and we have to be mindful. This patient now I've been following for 15 years, and dystonia is not much of a feature at all, and that usually melts away with levodopa. I'm actually going to just briefly tell you here. I'm going to skip to the one on the right for the sake of time. This patient on the right is what we meant by indicating that someone doesn't follow the rules of dystonia. It's a dystonia that is fixed. It occurred relatively quickly at rest, and these patients are often diagnosed with a condition called complex regional pain syndrome, which really is potentially explained because there are secondary autonomic changes in the vasculature of the skin, and makes the patients look as if they have this other. This is complex regional pain syndrome type 1, meaning without any nerve injury. But in reality, these patients, most of them at least, have psychogenic dystonia or functional dystonia. This is an example of the combination of blepharospasm or mandibular dystonia, which has often been referred to as MAGE syndrome. In this particular case, idiopathic to the best that we can. We always have to look at the history of drug exposure in these patients, and I think is very helpful. This is
When I walk, it's okay, but during the day, if I was thinking about something, and I changed the idea to another.
So very, very important to recognize that in this condition, if affecting the orofacial region, there will be involvement of speech. There are some syndromes that occur as a result of strokes. The man on the left, which also has an involvement of the speech, is a complication of a cerebellar stroke. And cerebellar strokes are going to do this about a year or so later. So you will have patients without any, recovering from their stroke and develop this dystonia at the end. Similarly, with the hands, the thalamic and carotid lesions, largely ischemic, but also hemorrhagic strokes, can lead eventually to quite severe deformities of the hand, which are very important to recognize. In terms of features that we need to keep in mind, these are just a list of them. So essentially what we're saying here is these kinds of things do not follow the rules of dystonia, and we have to be mindful that if we elicit any of this, we have to think of other conditions. There are a couple of conditions, though, that if you see them, you have to know exactly what it is. This is one of them. You can see it's paroxysmal retrocollis.
It looks like something beyond is.
Okay. Paroxysmal retrocollis, and as you see here, also involvement of speech, some extent of arm extension, elbow extension, wrist flexion, and internal rotation of the arms. If you see this pattern, the retrocollis, the extension of the arm, the flexion at the wrist, there is nothing other than neuroleptic exposure, and so this is tardive until proven otherwise. Just briefly, this is Risus sardonicus, is a very important feature in Parkinsonism. If it occurs within the context of levodopa, so this is a levodopa-induced dyskinesia, and dystonic dyskinesia, think of MSA, is one of the red flags. And I'm going to briefly go through, just want to make sure this is one condition we rarely see, Wilson's disease. This is the sardonic grin. You can see this is not the patient smiling voluntarily. This is making it look as if there was a half a smile. And that feature, that smile right there, keep that in the back of your minds. This is, if you see it that way, you have to think that you have to explore this patient for Wilson's, and you remember this year's Neuroball, this was one of the imaging features that was discussed. Finally, the combination of Parkinsonism and dystonia in a Filipino has to make us think of Lübeck disease. So that's a very important condition, and it's the only of the primary dystonias or genetic dystonias that has a pathologic correlate, which is this mosaic gliosis of the putamen. I'm going to skip the rest given the time. I apologize. This is one of the risks that I run into. If you see, by the way, this alien limb dystonic phenotype in a patient hospitalized, number one reason by series, particularly the Mayo series, number one reason is Creutzfeldt-Jakob disease. So prion disease have to be thought of in these particular patients. And all right, just a word on treatment. Focal dystonias are going to be treated with chemodenervation, with botulinum toxins. If only that cannot be done, or because the dystonia is spread or generalized, then we think of oral therapies, and ultimately, if oral therapies fail, then deep brain stimulation. These are just some of the therapies that have specific use, and they're in your handouts. And I just want to end by simply reminding you that if you recognize the key features of dystonia, the rules of dystonia is the fact that it's action-induced, position-sensitive, task specific. If you recognize these features, you can begin to think of where is in the body is distributed and come up with a very reasonable differential. So with that, I'll pass it back on to Oksana.